turned it on.
Perfect.
I'm all over this. Okay. So thank you everyone for coming. I appreciate you all being here today. You know, it's a tough time to make, and I'm glad people took time in the middle of a busy day to do it. We'll talk a little bit about how we're going to try and change this, make attending grand rounds easier a little further on in the course of the discussion today. So I have a few I'm Joe Neglia. I'm the chair of the Department of Pediatrics. I have a few goals for today. First is just to review some of the highlights of 2015. Then work through some mission-based reports on our clinical mission, where we're at in education and in research, and then spend a little bit of time talking about some of the things that we will be doing, focusing on as a department in 2016 and 2017, and hopefully leave time for questions. So obviously a lot going on with the integration between Fairview and UMP right now. Questions about what our relationship is or isn't with Children's, Health East, all these other places. So there's a lot happening, and I'm more than willing to answer as best I can. So in terms of highlights, new faculty, philanthropy and events, and then just recognitions. So first off, these are our new arrivals in 2015. We have 16 faculty that have joined us this year. Christine Evans from bone marrow transplant, Melissa Engel and Joanna Schurer from neonatology, Guru Hiramath from cardiology, and Ora Sanchez, Katie Larson-Nath and Jessica Stumphy in GI, Erin Marcotte in epidemiology, Jennifer McVean in endocrinology, Annie Laurie McCree in dogpaw, or general pediatrics and adolescent health. It's really not, doesn't have anything to do with dogs. Dana Grulich, Kamar Gustafson, and Zujaja Sadiq in emergency medicine, and then three more the hospitalist group, Sean O'Brien, Andrew Garfinkel, and Laura Hagemeyer. So a lot of new faces. We try and get these things out to you as people arrive, but I think getting to know people is really, really key. A lot of the research that may be happening on this side may fit into things people on the other side of that column are wanting to do too. So the better we can get to know each other, the stronger the connections we can make. I think it'll be good for the entire department. You know, this is offset obviously by losses last year. We did have about a dozen losses in the faculty, some faculty that moved on to other positions. Aaron Friedman retired from the faculty. He was pretty absent his dean time, but he officially retired last summer. And then the loss of Julie Ross, which is not quite a year ago and still has been a very, very painful thing for many. So we had a number of events, a number of philanthropic, a number of things that are really worth noting because they essentially are bringing our department out, what we do here, out into the community in Minneapolis, St. Paul, and even beyond. So one of these was Fashion Fest. This is an event that happens every spring. It used to be called Wine, Women, and Shoes. This sells out before anybody even advertises it. So if you want to go to it, you have to kind of keep an eye out because the tickets are gone before anybody can even send out a website. Eric Kaler says this is the most fun event he goes to every year. You can tell that's like the first event I've ever seen him not have a tie on. We have fashion models like Dr. Eckerly. It's actually a great event, but really is keyed to bringing the women's philanthropic community forward in association with the Department of Pediatrics and our Children's Hospital and what we're doing here now. Kevin Warren is the Chief Operating Officer of the Minnesota Vikings, and Kevin and his family have become very big supporters of the Children's Hospital here in the past couple years. This started with a gift in memoriam of his sister Carolyn, who died of breast cancer, and they created the Carolyn's Comfort Fund, which is used to support families here whose kids are either hematology oncology patients or undergoing transplant. Kevin is now taken to hosting dinner on Thanksgiving and Christmas Day for patients and families. It's a real, just wonderful relationship we have going with the Minnesota Vikings now that I think is certainly a source of support for the department that's really good. Pete and Mary Sue Vorbich. Pete is a finance guy and has given a very, very substantial estate gift to the department here to be used for greatest need of the department at the time of realization. So this means that it doesn't happen until he passes away. He's 10 years younger than me, so we're not anticipating this showing up anytime soon. But this kind of work that Elizabeth Patty and her team are doing is really helping position this department for very, very good things in the upcoming years. One thing that happened just a few weeks ago was the naming event for the Otto Bremer Trust Center for Safe and Healthy Children. And I want to take a little bit of time on this because it's instructive as to things we can all do to help build our programs here. So this started as a grateful patient referral. Brad Miller, who I don't see here, but that's what he looks like. Brad had a family who had expressed interest in giving to the hospital and giving to the programs, and this family was connected to the Otto Bremer Bank. And I don't know what the details of the conversation was, but Brad had the thinking on and referred them to the University of Minnesota Foundation, and Christy Flanagan Villar and Elizabeth Patty worked with these donors over a period of, I don't know, 6-8 months. It wasn't an instant one meeting thing to bring forward a gift that would be important to the donor as well as to the Children's Hospital. So Nancy Harper, we settled on with them on the Center for Safe and Healthy Children. Nancy Harper, who just came a couple years ago, took on the prospect of writing the proposal up and doing the formal presentation to the Otto Bremer Trust. And we were able to award the gift on March 14th. And that's a $2.5 million naming donation for the Center for Safe and Healthy Children that will fund infrastructure, hires, research, a whole lot of things going forward. So it's a great example of an idea that started with a family coming forward saying we'd like to do something and then being able to bring it on. Monday, we had from the opposite end of this in some ways, we had a wonderful meeting with Marshall Friedel. We actually had a lunch with Marshall. It's another interesting story of a person who rides the bus every day, heard Dave Lee's Gutter Bowl presentation in the morning talking about the University of Minnesota Masonic Children's Hospital. And Marshall rides the bus past this thing every now and then, kind of always had wondered what goes on here. So Marshall listened to it, called up University of Minnesota Foundation and arranged for a tour, gave a $10,000 gift on the first day. And this is not, he's not a magnet of a Fortune 500 company or anything yet, but he's a single guy who's not spent a lot of his money over his life, I guess, and now has endowed $1 million professorship in neonatology. So Marshall and Michael Georgieff and Kathy Bendel and I were able to get together with about 30 of his friends on Monday to celebrate that donation. It's a great opportunity to create new unrestricted monies that neonatology is going to be able to use to advance their mission. Blythe Brendan has been another tremendous supporter over the past year. She's given hundreds of thousands of dollars to support integrative therapies, integrative music, and family wellness. She's been the past chair of Wine Fest, Fashion Fest, and really just a tremendous supporter here. The Blythe Brendan Foundation's been a key. This year was the 100th anniversary of the Department of Pediatrics. It was easy to forget because it seems like so long ago now, but we just had dinner on September 17th over at the McNamara Center and pretty much filled the place up. We had a lot of our past faculty come back. David Brown was here, Chris Saxena was here, Ed Kaplan was there with his gold-headed cane. Ed was a recipient of the gold-headed cane this past year. So it was great to see Ed along with everyone else. In case you don't know, that's Elizabeth Patty. If you have grateful families, Elizabeth, raise your hand. She's the person you want to see. 65136. Yeah. So anyway, another big event for the department this past year. Wine Fest number 20 happened this year. This was held at the Depot. John Wagner was the speaker for Wine Fest this year. Strong support from across the university, the dean, the president of the university, very active live auction. This is coming up in just a few weeks now, and I would encourage you, if you've never been to Wine Fest, to come to Wine Fest. If you don't want to spend and can't get to the Saturday night event, either because it's sold out, which is getting there will be tickets available for the Friday evening event. That is a lot less expensive and a whole lot of fun. If you are a wine lover, there will be wines from 30, 40, 50 different, 80 different wines. You can't test them all and drive home. But there will be 80 different wines there that night. And the opportunity to, buy a ticket, come stroll around with your friends, taste some good wines, and say thank you to all these people that are supporting the hospital. And thank you to people like Kathy Bendel, Troy Lund, who are part of the Wine Fest committee and have spent, the better part of this past year actually getting this to happen. This event over the couple days will earn close to $1 million and create probably between $400,000 and $500,000 of unrestricted money for our department. So the more we're out there supporting ourselves and showing it's important, the more our donors are getting behind us. We opened this just a little over a year ago, amazingly. It seems like it's been part of us now forever, but a year and a half ago, we were having this talk in the Brennan Center, and we don't want to go back. So we have this 203-seat auditorium, 3 conference rooms. We had over 2,000 events in the first year here at the Wilf Center, and have had over 1,000 so far in 2016. So we are getting good use out of the Wilf Center, and the Wilf family is very happy with the gift. Happy families come back to you and help you later on. So this is really important. So all these events in aggregate that I just showed on the slide have resulted in just shy or maybe a little over $10 million for the Department of Pediatrics. Not all of those gifts will have been realized in 2015. They will be realized over years to come, but that's forming the groundwork of a level of support we have in this community to support the research and education that we believe is so important, and to support this hospital as it really seeks to grow and do more. So 3 key missions in the department, obviously: education, our clinical care, and our research. And I want to spend just a few minutes talking about each of these. So education, briefly update the residency, a little bit about EPAC, and then our new immigrant physician grant. So these are our residency recruitment statistics. It's amazing that between 2011 and 2015, we had this tremendous rise, not quite a doubling, but over 400 additional applicants into the residency program. I wish I could say that's because the University of Minnesota is so famous and everybody wanted to do this. This was part of a national match frenzy that everybody started to feel. There was growing concern among graduating medical students that they would not get into a residency program. And what was fueling that is not quite clear. I mean, when we actually look at the data across the United States, there are very, very few American medical graduates that are not getting into the residencies through the match, and the ones that are not getting in have had things that might lead you to expect they would have trouble matching. But anyway, we're all under this huge rise, capping out at over 1,000 applicants, not this year, but last year. The residency program had to essentially whittle that whole thing down to 182 interviews, 178 interviews. It's a massive commitment of people in this department to try and work that list down and not miss the gems in there, and also filter out all the Phi Beta Kappas that really wanted to go to Harvard and live in Boston and won't come, and make sure that we're taking people that really are likely to consider us and get here. So anyway, we did work through that, brought the number down to 178 interviews. 21 of whom were our own medical students. So a good sign. We've had good support from our own medical school seeing the programs, and then ultimately going on to match our 23 categorical residents and our 10 med peds with a little bit of addition that we're going to talk about. So the residency program continues to remain strong. John, Emily Borman-Shope, everybody involved with it has really put together an excellent program. And we continue to be well supported, continue to be well recognized nationally and internationally. So one of the new things that our residency has done, our residency and medical school have done, is EPAC. And I want to make sure people understand the importance of this. EPAC is Education in Pediatrics Across the Continuum. This is a brainchild actually of Debbie Powell, the former dean. Debbie envisioned a program that would take medical students who clearly had identified interest in a specialty, whether it be medicine, pediatric surgery, and help build their residencies, their medical school and residency experience toward that career. So you have to be willing to be identified actually in your second year of medical school. So the first cohort in EPAC transition to residency will be transitioning to residency between August and December of 2016. So this is that's what would have been fourth year of medical school. So why August to December? Because one of the keys of EPAC is that they're based on competency for advancement. They're not based on completing your surgery rotation and getting a passing grade. They're constantly reevaluated as they progress through their curriculum. Are they meeting the entrustable activities? Are they able to not just take a history and physical? Are they able to start to process the chief complaint, the history, the past medical history into a treatment plan? Are they able to start to do the work that an intern is going to need to be able to do? Most of them may hit that actually, 6 months or so during, 6 months or so earlier than they might have otherwise, and they'll be able to move forward at that time. Some people may actually take longer than that, and they will have the extra time they need to reach competency. So the amount of evaluation is huge for this group. And Betsy Murray, John Andrews, Patty Hubday, Emily Borman-Shope have all spent considerable effort creating the evaluation tools for this. There are 4 cohorts of this happening across the United States, and we happen to be the furthest down the road of any of these right now. So it's an exciting group, and we just took the second cohort of medical students who are going to start their clinical rotations this June. And Leah Krause, Matt Thompson, Aaron Belay, and Shane McWhirter are the students that are going to be the EPAC cohort number 2. So there's a lot of national look at this right now, seeing if we can actually start to move to competency-based assessments in graduate medical education rather than time-based assessments of everything. So there'll be, I'm sure, more to come on this in coming years. Last thing I wanted to mention about the education program are 2 new grants that the residency received this year. These are both from the Minnesota Department of Health. One is to support residency slots for primary care expansion, and the other is an International Immigrant Medical Graduate Program. And I don't know if you remember hearing about this. It was in the papers and talked up a little bit. The primary care expansion grant really is a response of the state of Minnesota to try and bring more physicians out into rural Minnesota. We have this collapse of physicians. Even though half the population of the state lives outside of the Twin Cities area, half the doctors don't live outside of the Twin Cities area. We do have this collapse here. So they were able to receive $180,000, especially to support flexible training for the EPAC pathway graduates. These people are coming in off cycle. It's going to create a little bit of havoc for the residency and its scheduling. So this actually gives us the flexibility to go up on our number of residents for the next couple of years to help take this on. The other program that we competed for and were fortunate to receive the grant for is the International Immigrant Physician Program. These are individuals who have completed their medical training elsewhere in the world, not Canada. Okay, Canada's out. But Africa, Southeast Asia, who have immigrated to the United States without a pathway. They've either left a bad environment in Africa, bad environment in the Middle East. They've come to the United States, and many of these people end up working as laboratory technicians. They can end up doing all sorts of things around because they can't find a pathway through residency and graduation, through residency to get actually back into practice, so what they've trained for in the past. One of my patient's mothers was an ophthalmologist in Africa. It took her years to finally find a residency in the United States, in Kentucky, where she then moved to with her family for a few years, completed a family practice residency, and came back here and now practices family medicine. But for years, she was just unemployed, and this is an ophthalmologist that had been practicing in Africa for years. So the International Immigrant Physician Grant actually allows us to bring individuals from those communities into the residency program. They have to come into a primary care residency, pediatrics, family medicine, or medicine, and they have to commit to doing 5 years in rural Minnesota after they have completed their residency program. So it's hopefully a win-win for everybody in this. The state will get good people out into primary care in rural areas. These doctors will get a chance to restart their careers here in the United States. And our residency actually gets the chance to competitively select from a very qualified pool of international immigrant graduates. So we have one individual from Sudan who will be starting the residency this summer. And then there actually is another graduate also from Sudan that's joining the regular pediatric residency. But both these people are very highly qualified, and we're excited about the opportunity to do this. So it's a neat program. Hopefully this works out well. Our clinical mission continues to be at the core of what we do every day. And I just need to look and see what time it is because we don't have a clock in here. Okay. Whoops. So a number of things that happened in 2015 that I think we tend to pass on and forget about. U.S. News and World Report rankings came out March, April, somewhere in there, May. We're ranked in the top 50 in 5 specialties, including neonatology, cancer, gastroenterology and GI surgery, endocrinology, and nephrology. We're the highest ranking hospital in the state in neonatology. We continue to finish second in the state to Mayo every year, which somehow manages to get ranked in like everything possible. But I think we had a very good showing last year in these. We also won the Minnesota Hospital Safety Award. This is an award that's given for innovative new ideas in making your hospital a safer place to be a patient. And this really was driven by the work of people like Abe Jacob and Sam Gupta, primarily around the creation of the daily safety call. So for those of you who don't know it, there is a phone call every morning at 8:10 or 8:15 that goes off every day that probably 40 people from around the hospital call into to discuss the events of the past 24 hours and raise any concerns, any errors, any potential errors that have shown up that last 24-hour period, so that things start to get acted upon in very real time. And the next day, the pathway to get those things resolved continues to be discussed. So it doesn't go through a lengthy process of going up a food chain to reach an administrator's desk somewhere who says, I really don't have time for this, and puts it in the pile for later. This is a real-time, rapid cycle implementation of things that will make the hospital safer. Best doctors in America, 140 UMP doctors were named from across the medical school. 68, not quite half of those were from our children's hospital. So a lot of very strong recognition, really, for the work that everybody here does. And it is helping a lot. Now, we need to continue to grow the clinical services here. And when we did our strategic plan a few years ago, we talked about a few things we felt were core to doing that effectively. One was growing and developing a robust quality and safety program. And I can stand here and tell you, I believe we're very far on the road to doing that. Is it done? Absolutely not. It's actually never going to be done. But, you know, we are committing additional staffing to it. We have not only started the daily safety calls, there are a number of quality improvement processes that have gone on. Our ventilator-acquired pneumonias at this hospital have gone down to essentially zero. Our central line-associated bloodstream infections have dropped. I didn't put in the preventable harm index slides, but we're actually going from what used to be maybe 10 to 15 events a month. We're now getting down to 0 to 3 a month. So we've made some real headway in there. We need to develop and enhance our existing programs and improve our referring physician access and communication. Our doctors that are referring in want to know what happened to their patients. So this is just to give you a sense of where we are in the Twin Cities right now. This is data from the Minnesota Hospital Association. So this is all based upon DRG codes and hospital discharges. It's less than perfect data, and if we're setting up research, we might not want to do it this way, but this is the way the data comes from the Hospital Association. So this is 12 counties, the metropolitan area, inpatient market share through the first 3 quarters of 2015. So the 2015 data that's annualized out, essentially. And you can see in 2011, when we moved over here, we're about 11% of the market. That has grown up, peaked at 14.6, had a dip in 14, rebound in 2015 to about 14.5% of the discharges. We are clearly not as big as Children's of Minneapolis and in St. Paul, but we are continuing to grow. And when you consolidate this along with our work at other Fairview hospitals, so our hospitalist program at Ridges, our hospital program at Maple Grove, our pediatric kids that are discharged from other Fairview hospitals, we end up with a little bit shy of 20% of the market share in general pediatric discharges. One of the things that's worth pointing out in this graph, you can see the lines here going up across basically almost all of the children's hospitals, and this all other thing is getting scrunched. We are truly seeing more consolidation of children's care across the larger places here in the metropolitan region. The smaller places are seeing less and less, and you start adding this group up, it gets higher, and this is getting higher and higher. So this market consolidation is very real. Neonates in this data refer to every baby that did not have the DRG applied for normal newborn. Okay, so this goes everywhere from the child that needed to be on ECMO to the child that needed to go to the special care nursery for extra observation because maybe they're worried about the bilirubin or something. So it can be that whole range. But again, this is the data we have to live with. And you see that we've been pretty consistent in the mid-6s, a little bit of dip in the last couple years, in part because of pressure from the new mother and baby centers that were going up across the Allina network. I don't think this would be 5.6 if we looked at this number today. I'm sure most of the people here in neonatology would agree that it certainly doesn't feel like 5.6. Census in the NICU lately has been limited by nursing, not by beds. And there have been a whole lot of days with over 50 kids in the NICU, which is dramatically different than it's been before. Interestingly, in OB, we actually are the market leaders. The combination of Fairview, Maple Grove, and North, this consolidation, this collaboration we have, is 31.5% of the OB market across the metropolitan region, with the Allina hospitals coming in at about 29% and then further on down the list. And finally, for the first time, we got 12-county market share data from emergency medicine. And you can see what everybody here knows is that the program in our emergency medicine department has grown dramatically. We're tracking I don't know, when we moved over here, what did we have? 3,000 or 4,000 visits, something like that. This year, we're tracking close to 16,000 visits. Yeah. So there's been almost exponential growth in pediatric emergency medicine here. Interestingly, when you actually look at this whole consolidated Fairview M-Health thing, we're really up to about 20%, 19% of the market share. So we have a lot of children being cared for at other Fairview sites, Ridges, Southdale, Lakes, that create really great opportunities for us to do things to impact the care of those kids, not just here, because most kids who need to go to an emergency department don't end up in an emergency department at a pediatric hospital. They end up at a community emergency department, and people like Jeff Louie are doing work to try and push out best practices to those community hospitals, so every kid that falls down and bumps his head doesn't get a CT scan of his head and neck. So how can we actually use what we can learn here to improve the systemness of what we do? So there are a number of growth strategies. These were identified by the hospital leadership. They include things like rebuilding the CV surgery program. No secret to anybody in this room that with the departure of Jim St. Louis and our failed attempt to do something with the surgeons at Children's, our CV surgery program really hit, if not hit the bottom, I think got pretty darn close. It was a tough period of time. Our new pediatric surgeon, Tony Izaki, started just about a month ago now. We have hired additional faculty into cardiology to support that. We are working to hire additional faculty into our cardiovascular ICU to support him. And the results we're seeing from the first 15 or 20 operations, I guess, have been outstanding. He's a very, very good pediatric surgeon. We will help rebuild this by leveraging our maternal fetal medicine and our neonatology positions in the community, because a lot of these kids are going to be diagnosed with heart disease well before they're born. We have a great partner in Dan Landers in this. We need to continue to focus on our very high-end bone marrow transplant and solid organ transplant. We also need to realize that our ED has been one of our great successes. And doing that right, especially as we reach out to other healthcare systems in the Twin Cities, is key for our future success. We have to have an effective way to bring those kids through our ED, or to bring our expertise out to people that need to talk to us. And the other thing that will happen here in September is we will move our St. Paul clinic. So we made a decision to let the lease go there on Smith Avenue next to St. Paul Children's Hospital. It was small. It wasn't supported by the St. Paul Children's physicians any longer. That ended with the consolidation of Minneapolis and St. Paul Children's. We have leased space on Tamarack Plaza, I think the name of it is. It's out off Tamarack Road in Woodbury. Anybody who knows that area better than me can correct me. But it is right next to a huge central clinic that Central Pediatrics just opened, and next door to a Health East clinic, and just down the road from Woodwinds Hospital. So this is, we are actually starting the design phase of that clinic. We'll end our lease on August 31st in St. Paul, and we will plan on moving and being ready to go essentially the week after in Woodbury. So this will be exciting. We'll go out there. We have a lot more space to do things. Rehabilitation services are going to join us out there. Behavioral services will be part of what we do. Dermatology will be out there. It'll be an exciting opportunity to really make a statement in the East Metro area. Okay. All right. Okay. This seems to have stopped doing what it was doing. All right. Help. Oh, hold on. I think I got it. Yep, we're not going to do our updates of the computer right now. Okay, other things that we're addressing regarding the clinical services, looking at moving some things to freestanding sites, freestanding status. Again, this is an evolution. We're a hospital-based program, and if you have a kid and you take them to a hospital-based program, you get two bills. You get the bill from UMP, and then you get the bill from the hospital. More and more, the insurance companies are saying, yeah, we'll pay your UMP bill, the hospital bill is your bill to pay, and that's not sitting well with families, and we have families that leave because of it. I know in pediatric oncology, we run an off-site clinic out there in Maple Grove rather, and we have families that just demand to be seen in Maple Grove. They are not interested in being seen here because of the, not even copay, just a refusal to pay. So we're looking at creating freestanding ambulatory clinics, especially over in the Park Plaza building as that building turns over with the consolidation in the clinical and surgical center across the river. We continue to look at our staffing and staff training. Neonatology is a good example of this, preparing for our increased volumes. International medicine is becoming something that we are addressing more and more. We've had a number of visits of faculty to the Middle East. We have a number of children that are here, pretty much starting this whole idea with the bone marrow transplant program, specifically around epidermolysis bullosa. But this may be something we really seek to grow out and do in an organized way. And we need to really look at our administrative structure here at the hospital to become more efficient, to become more responsive to the needs of kids. It's great being part of mHealth. There's huge advantages to be part of this big healthcare system, but we can't let those things overwhelm our ability to react to the needs of the patients here at our children's hospital. And research. So research clearly is a core part of this department. It's been as long as I can remember. Jim can remember back longer than me. Jim Mueller and I were just talking before Grand Rounds when he was interim head, and the number of faculty was 70, 50, and 30 some odd % of everybody's paycheck came from the state of Minnesota. That's not the way it is anymore. We're more like on our own these days. But research continues to be at the core of what we do. In 2015, we had 89 new grants and contracts awarded to the department. In R01s, Bruce Blazer had 2, Michael Kaiba, Mike Veneris, Tony Moran, Aaron Kelly, and Mark Slice all had new R01s or recompeted in R01. Mike Veneris and Mark both had RO3 grants. Dave Largaspada in R21, along with Ann Laurie McCree, one of our new hires in general pediatrics and adolescent health. John Wagner took over and successfully recompeted the University of Minnesota Program Project Grant for the bone marrow transplant program. This is a really, really big deal. You'll see that on the next slide. And then Logan Spector renewed his T32 grant that Julie Ross had formerly held. So a lot of success there. And to give you an idea of the size of some of these things, I just took the ones off the list that had more than $500,000 in direct costs. So the BMT program project is over $6 million. But if you look at the top of this list, you'll see there's a tremendous amount of diversity about where the money's going in the department. It's not just going to one place. It's going to bone marrow transplant. It's going to endocrinology. It's going to epidemiology and clinical research. It's going to pediatric oncology. It's going to infectious disease. A lot of people, submitting grants. It's a good time to be thinking about getting your R01 or R21 in. There is going to be more money at the NIH, at least for the next couple of years. And there may be more beyond that, especially if you're into cancer, because of the Joe Biden moonshot idea. So a lot happening on the research side. This translates us out again to be the eighth in the country in terms of NIH research support. So about $24 million this year puts us right ahead of Stanford, right behind Vanderbilt, ahead of places like Hopkins and UC San Francisco. Some of these things are huge, and they're just going to be a little more challenged to get to. But I do think one of the goals for our department would be to get to a point, a lot of this is driven by the CTSA grant. Now, That's the huge Clinical Translational Science Award that Bruce Blazer is the principal investigator of. That's going to be in a no-cost extension this year. So this is not going to look so good next year. We're going to be looking at somewhere in the teens. But what I'd like us to start looking at is what would it take to be in this top 10 list, and it's about $24 million, without that CTSA grant. And I think we're at a position right now where we can start to make the decisions to get us there. This is what it looks like just over time. Obviously, this is the CTSA award, big deal. And our standing, so immediately dropped it from 18th to 7th when the CTSA was awarded. With any luck, Bruce and everybody will be successful and the CTSA will be refunded. It probably is not going to be refunded at that level. None of the CTSAs are going to come in with that much money again. We continue to look at other parts of our research mission, our clinical research. So we have an active clinical research program here. At any time, there are over 250 active clinical trials going on in kids across our programs. We consistently have more than 1,000 enrollments each year. 15% of all the medical research, clinical research, is happening in children here at the University of Minnesota Medical School. So Amanda Gallister is the administrative oversight of this program, trying to make sure that we are out there with the staff support people need to do these studies, and not only do them, but make sure they get done right and safely. So initiatives. Grand rounds, we'll talk a little bit about the Masonic investment, faculty development, and integration, and then we will wrap up in time to have some questions. Grand rounds, beginning July, grand rounds will shift to 7:30 a.m. on Wednesday mornings. So we will leave this noon time, which is a difficult time, and we're going to move to 7:30 in the morning. There will be food, there will be hot coffee. We're going to ask that clinics and rounding not begin till 8:30. I do understand that this will cost us some money. I'm not that thick. I do actually get it. But it's hugely important that we have our faculty, our residents, and our students coming together once a week to actually become a little bit of a department community. Almost everybody in this room probably has been out there and given grand rounds at another center. And our attendance is not great at grand rounds. We have a river, we have all sorts of issues that challenge us. One of the things we can do is by shifting the time to start early in the day, at least avoid the clinic overruns and some of the other things that are so hard. So attendance is really an expectation of our faculty, our residents, and our fellows, and our students on pediatric rotations. So, you know, the students that are on with us need to come to grand rounds. Our residents that are over here need to come to grand rounds, and the faculty need to lead the way. So what are we going to be doing with the Masonic Gift? You know, we talked about this last year. The Masons have donated $25 million to essentially not to build anything, but really to build the academics and education of the department. Now, the Masons just didn't hand us a check for $25 million, right? So it's going to come in over time. And fortunately for whoever has this job down the road, a whole lot of it comes in right at the end of the gift. But right now we're in the small startup phase of the gift. But still, it's very, very important and very real money. So where is this going to go? Well, creating collaborations is hugely important, not just within this department, but outside of here. So part of this is going to fund the work that Muna Suni and Jennifer Kylo are doing, looking at culturally appropriate diabetes education in our Somali population. So this is through the Clinical Translation Science Institute here at the University of Minnesota. So we're going to continue this focus on collaborations. This will be the second year of the cross-departmental grants. Sheila McGinnis from dermatology and Lucy Turcott from pediatrics are working on mast cell disorders. Jeff Louie and Dr. Pothoff from Public Health are looking at unnecessary CT scans in emergency medicine. And then Sarah Cusack and I think Elizabeth, but I'm not sure, Frosch, are looking at iron stores and malaria. Again, specifically using the Masonic money to actually reach out across departments to get us doing things beyond ourselves. The other thing for this year is to look at early investigator awards. So this is a slide I showed the Masons. So typically you graduate from medical school around 26. This is assuming you just run the straight pathway. Finish your residency, do your fellowship, And if you're fortunate, you're on the faculty, you have a K award, and that's kind of winding up when you're 36, 37 years old. Now I know what the problem is. I can tell it. So the problem's here. This is the average age of the first NIH research grant award in the United States. It's been going up and up and up. So right now, for an MD, the average age is around 44 years. So the question is, how do we bridge those 8 years? You know, it's been a huge investment. All of us have made big investments to get ourselves to here. Departments have made investments. And all of a sudden we have basically this big gap. So we're going to be using this money to support some of our early investigators. And these are the people that are getting supported with this. Shane McAllister, who's working on HHV-8-associated cancers and treatment with propranolol. It's actually, Shane, I saw you walk in. There's a paper in Pediatrics talking about rebound after propranolol for hemangiomas. I just saw it this morning. So there is interest in this in a lot of ways. Annie Hall, looking at intrauterine growth restriction and neurotransmitters in the brain. Andy Barnes, who's been working on executive function in high-risk kids. And Rebecca Schlafer, who's been investigating the impact of maternal incarceration on children's outcomes. So we're going to be using some of the Masons money to help keep these careers on track until they can not necessarily get to 44.8 years or whatever it is, but at least get to a point where they start to receive their own funding. We also had some very novel discoveries this past year in osteosarcoma. So the Zach Sobiach Fund. Zach was a kid many of us took care of with osteosarcoma. He died. Zach was an incredible musician, and his song "Clouds," went off the wall. The family basically took the money and gave it to the department to do something for children with osteosarcoma. Brandon Moriarty is part of David Largasfata's lab. They found some targets for childhood for osteosarcoma. This is really the first research that has identified potential targets, and Brandon is working to bring those things forward. We have other great opportunities here. Our obesity program that Aaron Kelly and Claudia Fox are leading is not just addressing the simple overweight children. They're addressing the kids that are in most serious need of intervention. And they're getting research funding to do this. This has the feel, I haven't told Aaron yet, of program project someday. I mean, this really feels like it's going in that direction. I think as we look at using Masonic and other funds in the coming year or two, this should be an area where we're going to go. And we need to look at expanding our research portfolio. We do have breadth. It's still not as good as it needs to be. Our external site reviewers, brought that forward as well. So one of the things we're doing is embarking in a true faculty development program. And this year, Tony Moran has taken on the position of Vice Chair for Faculty Development. She's actually asked Kathy Bendel to take on the role as Associate Head for Diversity, but we're going to talk right now just about the faculty development program. This is just a draft of to where this is, nothing set in stone. So the overall goals: enhance the academic success, improve our engagement, our satisfaction, and our collaborations, become more effective as mentors, researchers, and educators, and develop our future leaders. So for the entire faculty, plans include increasing face time, getting to know each other through grand rounds. She wants to encourage divisional attendance through competition with cash rewards. We did not do the Julie Ross, the recognition banquet this past year. We'll do that again in January. It was a great event and a good time to come together. Believe it or not, Tony is getting some leverage at actually trying to turn the physician lounge into a place that people would want to go into again. So this is good. Again, it is an opportunity for people just to connect with each other that we miss. She didn't tell me about this one, so I have enough trouble writing it 3 times or 4 times a year, but we'll give it a shot. but then working with a number of our faculty to take the master's mentor course that's going on in the medical school right now, and then bringing that out to our other faculty. For assistant professors, making sure that every assistant professor has an appropriate scholarly mentor, often prior to hire, and developing their science, collaborative science early on. Making sure everybody gets into basic manuscript writing course. Mike Pitt has been leading something called P-Quad that I can't remember what all the P's stand for, but it's publications, performance, and peer pressure or something like that. But it's like a writing club to try and get people going on these things. And if you look at what's happened in the emergency medicine group this year, they have like, 12 presentations at PAS coming up in the next couple of weeks. I mean, it's really taking hold. And then working for quarterly development workshops. At the associate professor level, making sure our associate professors are thinking about their next step, their move to full professor. What are their goals? What do they need to do, and reviewing those. Taking the mentoring courses as a way to make sure they're going to be ready to bring on younger people. Looking at attending departmental development leadership meetings and leadership workshops. So all these things are getting really, hopefully, teed up to begin to happen in the next year or so, essentially strengthen our faculty even more. So last thing is integration. So we've been in this room a few times and talked about the integration between Fairview and UMP. We talked about it for not quite 4 hours last night at the UMP board meeting. We are really completing the due diligence phase where we're looking at each other's books. That analysis should be coming out in the next week or so. The negotiating teams are meeting for many hours, many times a week. I know that today they had 5 hours blocked to meet. We have a list of about 27 issues. We are probably down to about 3 issues where there's considerable disagreement between the parties. So it's challenging. You have some really strong proponents here, including the Dean of the Medical School and Bobby Daniels, who are going to these things and essentially negotiating every day to make sure that the academic and education interests are going to be strengthened through this alignment and not weakened through an alignment. So there's a lot going on. The timeline is obviously not rigid. They really want to get this thing done. They would love to see it begin July 1st, but it has to be done right more than just done. So that is happening a lot of time on that these days. Challenges. We haven't talked about some of these things. We have lots of challenges. We have a for-profit osteopathic school, I think, unless they bailed out, that is planning to move into the Twin Cities in the next year or two. They have already started to line up rotation sites for their osteopathic schools for their students, and in contrast to what the medical school does, where we say, wouldn't it be great if you had some medical students on your rotations and your wards? They're saying, we're going to pay you to do this. This is not a Twin Cities phenomena. This is a national phenomena. It's a real challenge, and it's going to be a challenge for our getting our residents and our students out into practices in our community hospitals. You know, like I said, we have an aligning pediatric marketplace, and we continue to have both connections and competitions with Children's of Minnesota. It's probably unlikely to change in the next year. We'll probably still be talking about this a year from now. We need to expand our research. We really do need to find ways into the top 10 without the CTSA. You know, it's great to have that grant. Blazer's not going to be the PI of that grant forever, even if we keep it funded forever. So we need to look for ways to do that, and we need to continue to balance our research, education, and clinical needs, which is not easy. And I think everybody recognizes it is not easy. So that's the presentation. There is a lot of good that has gone on this last year. There is a lot of challenges as doctors and nurses, and we tend to focus on our challenges. We don't tend to spend a lot of time thinking about what good might have happened. We tend to think about all the things we need to fix. But every now and then it's good to look back, and it is very encouraging to look at the things that happened this past year and the opportunities for the future. So thank you, and happy to take any questions. I know I've gone almost to 1:15. Questions? All right. Okay, thank you very much.
You have been